Hi everyone, I'm Sunam Sujanani, a hospitalist physician at Northern Light Eastern Maine Medical Center in Bangor, USA. Today I'll be talking about the association between SGLT-2 inhibitors and pancreatitis, a case report and review of literature. Type 2 diabetes is a leading cause of morbidity and mortality around the world. We have several treatment options used in the management of diabetes. SGLT-2 inhibitors are a new class of diabetes medicine that work by decreasing glucose reabsorption in the kidney, therefore increasing renal glucose elimination and reducing blood glucose levels. Empagliflozin, dapagliflozin, canagliflozin, and ertugliflozin are members of the SGLT-2 inhibitor class of medications that have been approved by the FDA. These medications are increasingly being used as add-on therapy in patients with inadequately controlled diabetes. Also, these medications have shown to improve cardiovascular and renal outcomes in patients with diabetes. Interestingly, dapagliflozin was shown to reduce the risk of heart failure exacerbation in patients with and without diabetes in the DAPA heart failure trial. Hence, as time goes on, we will definitely be seeing much more of these medications being used in clinical practice. Adverse effects reported with this class of medications include genitourinary tract infections, urinary frequency, and rarely euglycemic DKA. Here I'll be presenting a case which illustrates a case of acute pancreatitis precipitated by the addition of dapagliflozin, and this would highlight the possible association between SGLT-2 inhibitors and pancreatitis. So the case goes like this. A 51-year-old male with a history of type 2 diabetes, dyslipidemia, status post-cholecystectomy presented to the ER with a 4-day history of periumbilical pain radiating to the back. He had no history of recent alcohol intake or prior episodes of pancreatitis. On presentation, his vital signs were stable. His exam was remarkable for tenderness to palpation diffusely in his abdomen with no guarding or rebound. In terms of labs, he had no white count, his kidney function was fine, calcium of 9.5, lipase elevated at 262, triglyceride level of 203, and his last A1C level 1 month before presentation was 8.5%. CT abdomen pelvis showed findings consistent with acute pancreatitis. His home medications included dapagliflozin, which was started 5 days prior to admission, insulin detamir, the combination pill sitagliptin and metformin, and rosuvastatin. He was placed NPO and his outpatient oral medications were held. He was managed with IV fluids, antiemetics, and insulin, and his symptoms improved within 2 days and his diet was advanced. Upon discharge, insulin, metformin, and rosuvastatin were resumed. However, given the episode of pancreatitis, dapagliflozin and sitagliptin were discontinued. 1 month after discharge, glimepiride was added to his regimen by his endocrinologist. 3-month, 6-month, and 9-month follow-up visits revealed no further episodes of pancreatitis. However, due to increasing A1C levels, a decision was made to re-challenge the patient with dapagliflozin, in addition to continuing the concurrent regimen of insulin, metformin, and glimepiride. The patient then presented again to the ER 7 days after initiation of dapagliflozin with the same complaints of abdominal pain, radiating to the back, and nausea. His lipase was again elevated, and again he was found to have acute pancreatitis. Here's the CT scan revealing his findings of pancreatitis. Dapagliflozin was subsequently discontinued with resolution of symptoms. Since then, there has been no recurrence of pancreatitis. In our case, the patient presented with a picture of acute pancreatitis in the setting of newly introduced dapagliflozin without any other cause of pancreatitis like alcohol or gallstones. Furthermore, the recurrence of pancreatitis after re-challenge with dapagliflozin and the resolution of symptoms after dapagliflozin was stopped makes it a likely cause of pancreatitis. Review of literature shows 7 published case reports of acute pancreatitis attributed to SGLT-2 inhibitors. 4 of them were associated with canagliflozin, 2 with empagliflozin, and 1 with dapagliflozin, as you can see on the table. So in conclusion, this report highlights the possible association of SGLT2 inhibitors and pancreatitis. Patients and clinicians should be aware of this possible side effect, and patients should be informed about the symptoms of acute pancreatitis and advised to discontinue SGLT2 inhibitors in case such symptoms occur. Here is a list of the references and disclosures of the case has been published in Case Reports in Endocrinology. Thank you for your time and attention.